Thank you so much. I was waiting to hear the name this time. This invitation is sincerely an honor for me. Thank you. Metabolic dysfunction-associated steatotic liver disease is a disease previously known as non-alcoholic fatty liver disease. It is a highly prevalent disease. It affects about 30% of the general adult population. And this prevalence increases in line with the epidemics of obesity and diabetes, type 2 diabetes. Even more worrisome is the fact that the prevalence of the disease in the children general population is about 10%. And I think that this is a bad forerunner because in terms of individual and public health, the earlier the liver is affected, the sooner the complication of advanced disease appear. The prevalence of the disease is much higher in specific subgroups like obesity, patients living with obesity and type 2 diabetes, reaching about 70 to 80% of patients. And the fact is that half of these patients have not only have the disease, but have advanced type of the disease. So MASLD encompasses a phenotypic range. The good news, it starts from simple steatosis that it may progress to steatohepatitis, and that may progress to fibrosis, 1, 2, 3, 4 stages. The fourth stage is equal to cirrhosis. But the good news is that apart from this progression, the disease may also regress. Notably, there is the conception of that the sooner the management, the easier the regression. This means that it is easier to regress the disease when you focus at the stage of simple steatosis than the stage of third stage of fibrosis. Why is MASLD an important disease? Because it increases all-cause mortality. This is even higher in patients with advanced disease with steatohepatitis and fibrosis. It is important to note that the main cause of death in patients with MASLD is not liver disease itself, but cardiovascular disease, followed by extra gastrointestinal malignancies. About 45% of patients will die from cardiovascular disease, 20% from extra gastrointestinal malignancies, whereas only less than 10% will die from the complication of cirrhosis and hepatocellular carcinoma. So the liver is effective, but the patients die from cardiovascular disease and extra gastrointestinal malignancies. Fibrosis is the main prognostic histological factor for advanced disease, but also for mortality, all-cause mortality, liver-associated mortality, cardiovascular mortality, and cancer-related mortality. And there is an almost linear association between the stage of fibrosis and mortality. After this introduction, I will try to respond to the question, is MASLD associated with menopause? Experimental data provide evidence mostly for a positive association. And this is evident in most studies, in different studies and different animal models. So after ovariectomy, mice, rats, rabbits, etc., develop steatosis, hepatic inflammation, and fibrosis. It seems that all major cells in the liver, hepatocytes, Kupffer cells, which are the liver indigenous macrophages, and hepatic stellate cells, which are the key cells for fibrosis in the liver, have estrogen receptors. In the hepatocytes, estrogen binds estrogen receptor alpha, thus reduces de novo lipogenesis and increases the mitochondrial fatty acid beta oxidation. This results in reducing the accumulation of triglycerides and lipotoxicosis. In Kupffer cells, estrogen also binds estrogen receptor alpha, thus reducing hepatic inflammation. And in hepatic stellate cells, estrogens bind estrogen receptor beta, which leads to the downregulation of profibrotic genes in the liver. In clinical terms, this is one of the first studies linking menopause with MASLD. The prevalence increases gradually in women aged 20 to 50, and then it spikes, whereas in men varies little across all age groups. So, before the menopause, the prevalence of the disease is higher in men than women, whereas after menopause, it is similar or even higher in women. In this unique today meta-analysis, relevant meta-analysis of 12 cross-sectional studies, the odds ratio of the prevalence of the disease is about 2 times higher in postmenopausal than premenopausal women. 11 of 12 studies does not cross the line of no difference, which means that 11 studies show a positive association between menopause and MASLD. This result remain robust after adjustment for age and main metabolic risk factors. In this register-based cohort study, 40 years cohort study, it is underlined that women with premature ovarian failure, the baseline here is the age at menopause, the day of menopause, the prevalence of disease was higher in women with premature ovarian failure. However, these results should cautiously be interpreted because of the lower numbers of patients in group of premature ovarian failure. However, we can see that within 6 to 10 years after menopause, the prevalence is doubled in all age groups and is even tripled thereafter. In another cohort study from China, the disease was shown to be higher. The cumulative incidence of the disease was shown to be higher in postmenopausal than premenopausal women. What is more important in this study was that this result remained robust in non-obese women, but not in obese ones. What does this mean? This means that this may imply that obesity is a stronger contributor to the disease than menopause and may possibly mask any effect of menopause on MASLD. 13 years ago, we showed lower serum estradiol concentration in biopsy-proven postmenopausal women with steatohepatitis compared with those with simple steatosis. This may imply that menopause may possibly be associated not generally with MASLD, but also with advanced disease, and may also imply that even minimally changes in estradiol levels may have great effect for the great gain for the liver. In a more recent study, a nested case control study, the rate of the disease was double in postmenopausal women with type 2 diabetes compared with premenopausal women with type 2 diabetes. This result, similar results, was shown for moderate fibrosis, for patients with moderate fibrosis. Again, this means that the disease is associated, the menopause is associated not only with the disease, with MASLD, but also with advanced types of the disease, steatohepatitis and fibrosis. In a previous study, also, women, postmenopausal women with moderate advanced fibrosis and cirrhosis, the rate was higher than those observed in premenopausal women. Again, 30%, 55%. In another study, menopause was shown to be independently associated with hepatic fibrosis. What is important in this study is that the adjusted odds ratio of menopause was similar with that of dysglycemia and diabetes. It is highlighted that diabetes is an established contributor to advanced disease. Therefore, it seems that there is a triangle between menopause, dysmetabolism, and MASLD, which may possibly increase the cardiovascular risk. However, because things are not always linear in medicine and research, this important, in my opinion, study showed that in general, in the hepatocyte, estrogens have a beneficial effect on steatosis. However, there is a subgroup of women that carry this important for the disease gene, a single nucleotide polymorphism of a gene, PNPLA3. So the carriers of this gene have the opposite effect. It means that when estrogen receptor alpha binds estrogen response element of the gene, the peptide of this gene increases, adiponutrin, so the concentration of this peptide increases in lipid droplets, which is highly associated with the disease and its severity. So there is a subgroup of women that estrogen may have the opposite effect than what I have already said. Next, we will focus on the potential effect of menopausal hormone therapy on MASLD. Experimental data are clear again. Most experimental studies have shown that estrogen supplementation after ovarectomy have positive effects on hepatic steatosis, hepatic inflammation, and hepatic fibrosis. More recently, estrogen receptor alpha overexpression, specifically in the liver, was shown to protect mice from hepatic steatosis and hepatic insulin resistance. This was shown in mice fed on a high-fat diet, but not in those fed a controlled diet, regular diet, which may imply that estrogen may interact with the type of diet and weight gain. Overall, experimental data have shown that estrogen may stop the progression or trigger the regression of all phenotypes of the disease. In other words, experimental studies have shown that estrogen may improve hepatic steatosis, hepatic inflammation, and hepatic fibrosis. However, clinical data are are little conflicting. This is possibly the first study. One of the first studies have shown that menopause is associated with MASLD, and possibly the first study have shown that menopausal hormone therapy is associated with lower rates of the disease. Odds ratio 0.7. In another cross-sectional study from Brazil, the same result was shown. In this study, women on MHT was on lower risk of the disease. This author supported, however, that menopause was not an independent associated with the disease. I'm not very sure about this because in this regression model, they entered together obesity, metabolic syndrome, and insulin resistance. So there is the risk of over-adjustment due to multicollinearity. On the contrary, other authors have shown that women on MHT was at higher risk of lobular inflammation. They tried to support that this seemingly paradox is attributed to the role of progestogen, which may be true, but we need more studies to show this. I have brought here another study with contraceptive in premenopausal women because there are not, to the best of my knowledge, other studies with MHT in postmenopausal women. This study showed that when the contraceptive were based on progestin-only formulas, the rate of the disease was much higher than that observed in those receiving combined oral contraceptives. However, the numbers of these groups were small, and these results may be a little overrated. But of course, these studies grant other studies in postmenopausal women with different progestogen. The route of MHT administration in another topic warranted further research. In this study, 1 year, in this retrospective cohort study, 1 year after treatment, women receiving transdermal MHT had lower rates of the disease compared to those receiving oral MHT. Furthermore, the progression of the disease was also lower in those receiving transdermal MHT. Based on existing literature, we need studies to compare the effects of estrogen monotherapy versus combination of estrogen and progestogen, to compare progestogen neutral to lipid profile, microionized progesterone, dihydrogesterone versus progestogen non-neutral, and of course to compare transdermal versus Perros administration. Finally, I would like to say a few words about the 2 medications specifically approved for adult patients with MASH, steatohepatitis, and moderate to advanced fibrosis. The first one is resmetirom, which is a selective thyroid hormone receptor beta agonist. Why beta? Because we want this to act in the hepatocyte to improve steatosis, inflammation, and fibrosis, but not in the cardiac cells, bone cells, and skeletal muscle cells. Based on these phase 3 studies that meet both endpoints, resolution of MASH, steatohepatitis, and improvement of fibrosis, the FDA approved the medication for patients with MASH and moderate to advanced fibrosis. 1 year ago, and this was followed by an approval by EMA. The second medication is semaglutide at the dose used in obesity, 2.4 milligrams subcutaneously per week. Again, semaglutide in this phase 3 trial met both the endpoints, and FDA has approved the medication, and we expect that EMA will do the same soon. So, MASLD could not be recommended as long-term treatment of MASLD in women because MASLD may be used for a certain time frame in a woman's life. MASLD is common after menopause, so any potential effect of MASLD on MASLD may be considered before MASLD initiation and during the follow-up. And selected adults, including postmenopausal women with steatohepatitis and moderate to advanced fibrosis, may be eligible for treatment with resmetirom or semaglutide. Thank you very much.